اوكي، صباح الخير جميعا. بشرفني اكون اليوم بينكم في مؤتمر القدس الطبي الاول. محاضرتي اليوم عن updates on familial Mediterranean fever. طبعا this is somehow familiar topic to all physicians in Palestine regardless of their specialty. Familial Mediterranean fever is considered the prototype of autoinflammatory disorders, and it has actually opened a new chapter in rheumatology. Despite the advances in our understanding to this disease, the disease continues to challenge us. Okay, هذا الأوتلاين تبعي. To start with, FMF is the most common autoinflammatory syndrome. And what we mean by autoinflammatory syndromes, they are diseases that are characterized by recurrent fever and seemingly unprovoked inflammation in the absence of high titers of antigen-specific T cells or autoantibodies. It is characterized by recurrent, unpredictable, short attacks lasting from 12 hours to 3 days of fever and serositis. The link to the Mediterranean fever gene was discovered in 1997. The gene is located on the short arm of chromosome 16. It encodes a 781 amino acid protein called pyrin, which is predominantly present in cells of the myeloid lineage. So far, more than 391 mutations in these genes were discovered. And the gene comprises 10 exons. Usually the mutations in exon 10 are considered to be severe mutations, like the mutation M694V. Usually patients presenting with this severe mutation, they have early onset of disease, they have severe arthritis, erysipelas, they require high doses of colchicine, and they are at risk of development of amyloidosis. Whereas the mutations in exon 10, they usually cause mild non-specific inflammatory response or an FMF-like disease presentation. For example, the E148Q is considered as a variant of unknown significance. So it wasn't until 7 years ago when the role of pyrin gene was discovered, and it was found that pyrin acts as a pattern recognition receptor to detect pathogen virulence activity. So it was found that the cytotoxin of Clostridium difficile causes or triggers the assembly of the pyrin inflammasome by recruiting an apoptosis-associated speck-like protein associated with a card procaspase. And this was found to happen through the RHO-GTPase interaction. So what happens is that the cytotoxin causes inhibition of RHO, and this in turn leads to decreased phosphorylation of the pyrin gene by the GTPases. And so the getting rid of the pyrin will become less effective, and so this will lead to activation of the pyrin inflammasome, which will in turn lead to propagation of the inflammatory response with activation of pro-interleukin-1 beta into interleukin-1 beta and the propagation of the inflammatory response. We know that FMF is common among Arabs, Armenians, Turks, and Jews, and we were asking why is that? Probably we know because consanguineous marriage is very common in our region, but then the selection theory came into light, and just recently there was another groundbreaking article which found that patients who have mutations in the MEFV gene were in fact resistance to Yersinia pestis, which is the causative agent for plague. So it was found that those who have severe mutations mount a more severe interleukin-1 response in comparison to those with milder mutations. Now coming to the manifestations of FMF, so usually patients can present only with recurrent attacks of fever in the childhood period, or let's say the infantile period, and then they might be prone to develop serositis, whether it is pleurisy, peritonitis with localized or generalized abdominal pain, arthritis, which is usually transient, but in 5 to 10% of cases, patients might have protracted arthritis. And they also can develop erysipelas. And this is a picture for one of my patients having erysipelas, which is the skin lesions that we see in the lower limbs, on the dorsum of the foot, and the ankle. It is usually erythematous and tenderness, and sometimes might be mistaken for cellulitis. Also, patients with FMF can develop pericarditis, but it is less common. Patients of FMF are known to have more prevalence for some vasculitic disorders like polyarteritis nodosa, Henoch line purpura. However, they have decreased prevalence of autoimmune diseases like SLE. And we know that one of the most devastating complications of FMF is amyloidosis. Patients might have asymptomatic proteinuria going on from 2 to 13 years, and then might develop progressive renal failure requiring renal transplantation sometimes. And these are the factors that are associated with the development of amyloidosis. Male gender, M694V mutation, which is very common in our population. Family history of amyloidosis, poor compliance to colchicine, having serum amyloid A1 alpha-alpha genotype, and the country of origin. Now I'm going here to present a few of my patients who had some of the, let's say, uncommon FMF presentations to the non-rheumatologist. So the first patient was a female of 3 years of age who presented to the rheumatology clinic because of recurrent arthralgias and limping noticed since the age of 2 years. They used to last for a few days, and then she is fine. She had a history of DDH, and the mom mentioned history of recurrent abdominal pain, but she denied history of recurrent fevers. Her investigations during one of these attacks showed mild microcytic anemia, high inflammatory markers. She had a normal chemistry, including normal muscle enzymes, normal thyroid function test, negative serology, and a normal hip X-ray. So because of the periodicity of the disease, FMF genetic testing was sent, and she was found to be homozygous for the M694V mutation. And this is a frequent presentation for this mutation in this age group in the patients that I am seeing. Another patient is a 7-year-old male patient who was admitted to the pediatric ward of Maqasid Hospital because of exertional myalgia or weakness, mainly to rule out metabolic myopathy of 6-month duration, which is used to be relieved by rest. On further history, mom mentioned history of fever of 3 days duration happening every month. The patient had extensive workup, which showed normal CBC, high inflammatory markers, normal chemistry, normal muscle enzymes and thyroid function test, normal metabolic workup, and normal echo and negative serology, and some X-rays and MRI were done before the consultation. And again, the patient was suspected to have FMF, and he was found to be homozygous for the M694V mutation. And this is actually exercise-induced myalgia, which is a typical manifestation of FMF. Female patient who was admitted to hospital because of fever, abdominal pain, and vomiting with inability to walk and significant myalgia of few days duration. She failed to improve despite giving her NSAIDs and supportive management. She had extensive workup which showed only high inflammatory markers but normal muscle enzymes. So on exam, she was found to have a significant tenderness in the pelvic area and the hip area. So MRI was done, which was consistent of inflammatory myositis. So again, the patient was found to be homozygous for the M694V mutation, and this is one of the devastating complications of FMF, which is protracted febrile myalgia. Patient can present with prolonged fever, and they only respond to steroids. Okay, this is a sample of my FMF patients coming to the pediatric rheumatology clinic. So it's a descriptive data. As once data extraction is done, we are looking to do a phenotype-genotype association study. So it was done retrospectively. We found mild male predominance in this cohort of patients. The mean age of onset was 4 years plus minus 3.11 years standard deviation. The family history was found in 68% of the patients, and 44% were consanguineous. Among them, 77% were first cousins. 6% underwent appendectomy, which were negative. So fever, as expected, was the most common presentation, followed by the GI presentation. Okay, because of the shortage of time, I'm going to skip some slides. Okay, so shortly regarding the FMF genetic testing, the first 4 mutations are some of the most common mutations that we see, and they are disease-causing mutations. And once you see them, especially in a homozygous pattern, you can, if the patient has the appropriate phenotype, you can say that they have FMF. The E148Q is considered as a variant of unknown significance. However, if it is associated with one of the disease-causing mutation, it is almost always symptomatic. Okay, now regarding the management, why do we treat patients of FMF? Mainly to prevent the acute attacks and to prevent amyloidosis and to minimize subclinical inflammation in between the attacks. A wrong practice is giving these patients FMF only on demand or giving them very high doses of colchicine during the attack. This will not help prevent amyloidosis. It will not help minimize the subclinical inflammation that happens in between attacks, and patients might be predisposed to toxicity. The dose of colchicine roughly is 1 tablet, whether 0.5 or 0.6 in those below 5 years of age, 1 to 2 tablets from 5 to 10 years of age, and 2 up to 4 tablets in those above 10 years of age. And we usually escalate therapy if they are not responsive. Dosing can be given as a single or divided dose. Giving them as a single dose will improve compliance. However, they will be exposed to more side effects. We know that colchicine is a lifelong treatment. However, in patients who have only a single mutation, if they remained asymptomatic for more than 5 years and if the inflammatory markers were normal, we might consider stopping the colchicine and see what happens. If symptoms recur, we should restart medications again. The most common side effects of colchicine are the GI side effects, the nausea, the diarrhea, sometimes giving the medication in splitted doses can help, or avoidance of lactose diet. Rare side effects are bone marrow suppression, neuropathy, and myopathy. And males, there were reports of gonadal toxicity, but it is usually reversible. Some medications might interact with colchicine. We should remember that, including the macrolide antibiotics. Lastly, we should know that there are medications that can help the FMF patients other than giving them colchicine, which are the interleukin 1 blockers that we tend to use in patients who are colchicine resistant. And recently, canakinumab was approved by the FDA to be used in these patients. This is a very expensive medication that I don't think we will be able to afford in our country, but we can use anakinra at a dosage of 1 to 2 milligram per kg per day. Usually, it is given subcutaneously daily. So my take-home messages is that careful history is the key for the diagnosis of FMF, and this should be supported by genetic testing. However, sometimes it might be very difficult to interpret. Our patients should be followed up regularly to help them prevent the complications. And sometimes if patients are not responsive to colchicine, we should reconsider the diagnosis or think of other coexistent autoinflammatory disorders. If not, they might be colchicine resistant, and then we should think of using the interleukin 1 blockers. Thank you very much, وإن شاء الله نلتقي في القدس في العام القادم.
شكرا. في أسئلة يا جماعة؟ واضحة المحاضرة، بدهاش أسئلة يمكن. تفضل. لا الدكتور صوته عالي، صوته عالي. والله صوته عالي ما شاء الله، جهوري.
صباح الخير للجميع، يعطيكم العافية. طبعا هناك يعني بنسمع انه مرضى الاف ام اف انه يفضل يعمل لهم ابندكتومي. Is it indicated or not؟
اوكي، هو بصراحه هذا براكتس منتشر عندنا في فلسطين. انا لما رجعت كنت شوي سربرايز من هذا البراكتس، وحاولت حتى ادور في الليترشر اذا في محلات تانية بيعملوه. وشكله على ما يبدو اكثر في منطقتنا هو ما في انديكيشن ينعمل ابندكتومي. انا بشوف كثير مرضى بيقولوا لي انه حكوا لنا لازم نروح نعمل الكتيف ابندكتومي، او انه في منهم كثير عملوا. وانا حتى سالت اكسبرت في هذا الموضوع، ورد اكسبرت في هذا الموضوع. اذا احنا ضامنين انه يكون عندنا جود كومبلينس جود فولو اب للبيشنتس، طبعا مش لازم نعمل ابندكتومي بالنهايه عمليه. وفي حتى استدي نشروها عن الريت اوف ابندكتومي في مرضى الاف ام اف، فوجدوا انه نسبه حوالي 80% من هذول المرضى بنعمل لهم ابندكتومي يعني فور نو ريزن. فانا شخصيا لا، مش مع هذا التوجه، ولكن لازم نضمن انه هذول المرضى يتابعوا بشكل صحيح. بس ما هي عمليه يعني لها كومبليكيشنز. إذا صار له شيء من العملية مش راح ينام الجراح طول عمره. بس هو مش صح. صحيح صحيح. صح صح.
يعمل لنا التراساوند او سي تي حتى يطلع لنا دياجنوز ات از ابندكس اور نوت. اليوم في عندنا مور ادفانتج بروسيجر، عشان هيك عم بتقل او ممكن تكون توتالي مش موجوده. هذا يعني الوضع اللي كان في الماضي وفي تغير.
دكتور سيما يعطيك العافيه، شكرا على المحاضره. بس حاب اسال، كان السؤال ساله دكتور زياد، لانه احنا شايفين عن جد هازارد اللي عمال الكل بيعمل ابندكتومي وذاوت انديكيشن. بس هي كمسج. السؤال الثاني على غرار مثلا سيستيك فايبروز، وي هاف مثلا نوفل ميوتيشن. في عندنا نوفل ميوتيشن اف ام اف عندنا هون في فلسطين اتعمل شيء؟
هلا احنا عندنا في فلسطين معروف انه تقريبا اكثر من 75% من الميوتيشنز اللي هي الكومن، اللي هي الام 694 في، الام 608 اي، والفي 726 اي، يعني هم هدول اللي حكيت عنهم انا الكومن. بس احنا طبعا بنعمل مرات يعني هدول اول 4 احنا موجودين عندنا بشكل كومن زينا زي البوبوليشنز اللي كومن فيها الاف ام اف. هدول بشكل حوالي 75% من الميوتيشنز، هدول معروفينهم ديزيز كوزنج ميوتيشنز. هلا احنا مرات بصراحه في اوفر يعني بنطلب فحص الاف ام اف بشكل كثير. يعني مرات مريض عنده ديلي ابدومينال بين بنروح بنطلب له اف ام اف، بنلاقي انه عنده هيتروزايجس لوحده من الميوتيشنز اللي اوف انون سيجنيفيكانس. هل هي اف ام اف؟ هاي مش اف ام اف. هلا في البدايه لازم نسال حالنا هل الفينوتايب فيتس مع الاف ام اف ولا لا. بعدين اذا الفينوتايب فيتس لازم نطلع على الجينوتايب، لانه في كثير مرات يعني معروف خاصه في الاطفال انه ممكن تحت يعني في عمر مبكر يجوا باف ام اف لايك برزنتيشن وريسبونسيف للكولشيسين، بس ما تكونش اف ام اف، وليتر انه يعني تروح السيمتومز. فلازم نكون انه فيري كيرفول انه نسميهم اف ام اف ولا لا. هلا هل في شيء؟ طبعا بيطلع عندنا مرات كثير شغلات هي اوف انون سيجنيفيكانس. هلا في بيقدر الواحد على موقع اسمه الان فيفرز، هدول حاطين 391 ميوتيشن وحاطين السيجنيفيكانس تبعها اذا باثوجينيك ولا بناين او غيره.
خف عليها حكيم شوي خف